It's a great time here at the university and the UofL healthcare system. My name is Jason Chesney. I'm the director of UofL Health's Brown Cancer Center. I've been given the honor of introducing today's speaker for Grand Rounds in the Department of Medicine, Dr. Beth Riley. Dr. Riley graduated from the UofL School of Medicine a long time ago. I didn't realize how long ago until I looked at her CV this morning. It was 2002. She then completed about 6 years of training after medical school in internal medicine, and then hematology and medical oncology at Deaconess, which is part of the Harvard Medical School system. Fortunately for us, she returned to the University of Louisville after that and joined our faculty here at the Brown Cancer Center. Since then, she's risen through the ranks. She was an assistant professor the first time I met her, and now is a full tenured professor. She's become our deputy director for health affairs, which has a very significant role in the expansion of UofL Health. She's very active in national organizations and was recently named a very prestigious role as the governor of the Kentucky chapter of the American College of Physicians. In addition to being the undisputed top breast oncologist in the region, Dr. Riley helps coordinate and support the clinical and research efforts of over 40 UofL Health oncologists, and she's been instrumental in expanding the oncology service line across the UofL Health network. One of her early accomplishments after the acquisition of the network was to operationalize our new Brown Cancer Center Northeast facility, which has turned out to be a huge success under her leadership. It's a beautiful facility, and it's really brought our oncologists out to the East End and Central Kentucky, and as well as our multidisciplinary subspecialty cancer care. So without any further ado, I'm going to ask Beth to take the mic. Beth?
Thanks, Jason. I would just like to point out that you graduated long before I graduated from med school, just for the record. So thanks for having me today. I'm always excited to talk about what I do. I feel very blessed to work here with the colleagues that I do, and I think we've created a great breast program, and today I'm going to highlight one aspect of that, which is the HER program, which is a program that we started here for young women with breast cancer. So I have no disclosures. So for those of you who have not heard about the HER program, it's a regionally unique program that aligns collective expertise for the unique needs of younger women with breast cancer. We define younger women with breast cancer to those to be under 45 years old. The goal of this program is to improve outcome and quality of life for these women. It has a strong focus on fertility preservation and sexual health. So the CDC estimates that 1 in 10 women will be diagnosed with breast cancer will be under the age of 45. Incidence is increasing slowly in women under 50, while declining in other age groups. The reasons for this are probably multifactorial. I think, the rising obesity, especially in younger women, may contribute to this. There's delayed family planning, which puts you at increased risk of breast cancer, increased use of alcohol and oral contraceptives, menarche at an younger age, and the decision for nulliparity. So all of those are known established risk factors for breast cancer and increasing specifically in this population, which may be one reason that we don't see the incidence decline in this group. Despite its relative infrequency, it's important to realize that it remains the leading cause of cancer death for women under the age of 40. So really understanding this patient population and trying to improve that outcome is important for these young patients. So breast cancer survival also continues to improve with better screening, awareness, and more effective therapy. But these improvements often lag behind or absent in young women with breast cancer. Improvements are really delayed in a lot of high-risk groups, including the very old, the very young, and some socioeconomic disparities that we won't talk about today. One reason that these women probably have delay in improvement may be underrepresentation in clinical trials that help guide us in evidence-based clinical management. These women require complex multidisciplinary care to really give the best outcome for both medical and psychosocial aspects. And because of this, we wanted to start the HER program here in our region. So let's look a little bit at these outcome differences. So as you can see in cumulative survival probability, overall survival, it's most at risk for the very old, so this is greater than 80. But then you see it does not go down as you would expect with declining age, and here the less than 30-year-olds increase in terms of risk of death compared to other age groups. When this looks at breast cancer specific survival, you can see again less than 30 have the worst outcome. The cause of this disparity is not well known. There's a wide hypothesis range in terms of biologic factors or host factors, specifically pregnancy-associated breast cancer, or things like non-adherence a little bit, which we will cover today. But first we want to figure out, is age really an independent risk factor for breast cancer mortality? So let's look a little bit at the biologic differences. Because relative lack of screening in this age group, these patients are more likely to present with symptomatic disease. But they're also more likely to develop aggressive subtypes, including triple-negative breast cancer, HER2 overexpressed, although within this group, hormone-positive breast cancer remains the most common of all subtypes. Even within the estrogen-driven breast cancer population, these patients tend to have a higher grade. So you can see here the rate of grade and stage increases with youth and declines as patients age. Similarly, the rate of hormone-positive disease increases with age, with younger patients more likely to be hormone-negative, but again, hormone-positive breast cancer remaining the most common within this subgroup. So it's a good opportunity to review breast cancer heterogeneity, biologic subtypes, so that we can move forward and understand the differences in outcome within these patient populations. So we classify breast cancer based on 5 main types: luminal A and B, which are highly ER-driven, luminal, which is ER positive plus HER2 enriched by itself, and triple negative or basal cell subtype. So about 65% of patients fall in this luminal category. These patients have a lower proliferative rate. They tend to have a lower grade. They have a lower relapse rate and overall are more favorable prognosis than the other subtypes. HER2 positive disease accompanies about a 20% of the patient population. They tend to be a little bit more unfavorable, continue to have a higher proliferative rate, and have a Ki-67 in the mid 30s to 40s, whereas triple negative, even a higher unfavorable rate, more responsive to chemotherapy, tends to be a worse prognosis, but largely because of the absence of targeted therapy in this disease. So you can see the biologic differences in subtype of breast cancer based on age. So here we have 15 to 39%, 40 to 49, and those over than 50. So you can see luminal A and B is the most common subtype in patients older than 50, but this relative frequency declines with age. You see much more triple negative disease. Overall, you see a higher proportion of HER2 positive disease. So the question is, given that these two subtypes, HER2 overexpressed and triple negative disease, tend to have a worse prognosis, is this the reason for outcome disparity? So Ann Partridge is a leader in young women's breast cancer out of the Dana-Farber, and she has done excellent work looking at specifics of breast cancer mortality related to age of diagnosis. Here you can see a table that looks at the hazard ratio of death. This is just adjusted for demographics. This is adjusted for biologic features, subtype, and then symptomatic presentation. So you can see the hazard ratio for those less than 40 compared to the 50 to 60 group was chosen as the reference range is 1.9. As you adjust for biologic features, the hazard ratio declines, but it's interesting to point out that their patients are 50% more likely to die even when adjusted for biologic features. So it's not clear that explaining the subtype is enough to explain the outcome disparity. So when we look at this specifically related to breast cancer subtype, here you see luminal A, luminal B, HER2, and triple negative. Hazard ratio being the highest, therefore, for luminal A disease, comes down the hazard ratio is closest actually for HER2 subtype, which is an interesting notation, but really the development of targeted therapy in the HER2 disease, which is independent of menopausal status, which has become a common theme in patients with luminal disease, has really equalized across age groups, and the outcome is very similar. So looking at this, we wanted to understand, are there differences in gene expression within these tumor types that may explain this difference? And so here's some work done by Dr. Azim, a pooled analysis of gene expression over 3,000 patients. And I just mentioned here, they have a higher expression of RIKE ligand, c-KIT, and luminal progenitors, and PIK3 pathway is more disrupted. And those that I've highlighted here are abnormalities in which we do have targeted therapy that may eventually prove to be more useful in this patient population and is currently under investigation. One theory as to why disparity may exist in this patient population, especially in the luminal disease category, is undertreatment. So there's suboptimal treatment in this category in these patients, which has come out as a result of large clinical trials published in 2012 and 2014. So prior to these trials, the standard of care for endocrine therapy for these women was 5 years of tamoxifen. What these two trials show is that more aggressive ovarian suppression needs to be applied, and perhaps longer duration of therapy in this particular population. So SOFT and TEX were two hallmark trials looking at the role of ovarian suppression. Prior to this trial, we didn't really use ovarian suppression regularly. The only patients who underwent prophylactic oophorectomy were those harboring a genetic mutation, putting them at increased risk of ovarian cancer. And as a strategy, ovarian suppression was not widely used. Both of these trials were combined for analysis, looking at patients who received chemotherapy, a large proportion of which was nodal positive disease, overall high-risk women, looking at combining tamoxifen or aromatase inhibitors with ovarian suppression compared to standard of care at that time, which was tamoxifen alone, to see if we could any difference in outcome. In the very young population, the benefit was most pronounced. So you can see here is breast cancer-specific survival. Tamoxifen is this black line. Exemestane, which is an aromatase inhibitor, is this red line, and tamoxifen plus ovarian suppression is the blue line. So you can see the absolute improvement in breast cancer-free survival and disease-free survival with the aromatase inhibitor and ovarian suppression arm was significant in the less than 35 age group compared to the overall patient population. And just to put this into reference, this degree of benefit, around 15.7%, is on the order of what we see in the most effective chemotherapy subgroup. And so really, ovarian suppression in this patient population may provide as much or more benefit than chemotherapy. However, ovarian suppression in this patient population is significantly toxic. So about 16.7% of women in this group stopped tamoxifen based on toxicity. Of note, 21% of tamoxifen alone also discontinued early. And you can see the rates of non-adherence increase. And it's important to remember this was in the context of a clinical trial. Typically, clinical trial patients have a much higher adherence rate because they're highly motivated patient population. Looking at this in the real world, Dr. Hirschman did a survey of nearly 9,000 early stage breast cancer patients to really understand what is their rate of compliance or adherence to these drugs. She and colleagues measured three things: the rate of non-initiation, which is never starting the drugs, the rate of non-adherence, which was classified as taking less than 80% of the prescribed dose, early discontinuation of the drugs. And you can see here, discontinuation is in yellow, non-adherence is in blue. Extremes of age are at the highest risk of both of these, but less than 40 stands out as the most at-risk patient population. About 30% of overall patients in this study discontinued early. Of those who continued, only 70% were adherent. So they calculated about less than half are fully adherent to the full 4.5 years in which this study went on. This disparity is most pronounced in those less than 40 and an actionable area we can probably improve outcome. So why the rate of non-adherence or non-initiation? Based on survey results, a lot of the reasons that women discontinued these drugs had to do with a desire for future fertility, either at diagnosis or somewhere alongside their treatment course. Other reasons for non-initiation had to do with an early stage breast cancer, a stage 0 breast cancer, which was ductal carcinoma in situ, or the fact that they had declined radiation therapy, which may suggest that the understanding of the role of endocrine therapy in this disease may not be as valued in patients who required less or chose less therapy, and may be a point of education. Reasons for patients, stated reasons for non-initiation, delayed initiation, or early discontinuation also show concerns about side effects and fertility, both for non-initiation, delayed initiation, or early discontinuation. So again, creating some program that can address these issues is important to improve adherence and then overall outcome to really get the benefit from these drugs. So what are the side effects that these drugs cause? So here's your aromatase inhibitor plus ovarian suppression. In this patient population, your blood level estrogen is virtually zero. It's less than that of a postmenopausal woman. In tamoxifen plus ovarian suppression, patients have an estrogen serum level consistent with that of a postmenopausal woman. But the tamoxifen causes estrogen blockade, so that estrogen cannot be used. So typically, because of the lower bloodstream level of estrogen in the aromatase inhibitor plus ovarian suppression group, the side effects are more pronounced. Typically, the only side effect that's more pronounced in the tamoxifen plus OS group is really hot flashes. But you see depression. I wanted to point out depression is a significant side effect in both of these cohorts, and is something in the real world that we need to screen for readily. Musculoskeletal symptoms such as arthralgias and joint pain are much more common in the AIOS group than in tamoxifen, and sexual side effects are very pronounced. Vaginal dryness around half of women, decreased libido a little less than half of women. So let's look a little bit more at the sexual side effects. This affects adjuvant, metastatic, and high-risk patients, and truthfully, this is true for patients of all ages, not just the very young. However, because of the rapid decline in estrogen level, it is often more pronounced in this patient population. Aromatase inhibitors are worse in terms of a side effect profile than tamoxifen. And in this same study, looking at survey of discontinuation, you can see that the rate of AI discontinuation is much more than tamoxifen alone. Patient-reported outcomes are significantly worse with ovarian suppression. Overall, you can see that the tamoxifen line versus the ovarian suppression line, there's a wide gap in in quality of life measuring, and within sexual dysfunction, this also persists. So when this data was presented, even though the benefit was significant, there was a lot of discussion about the true impact, and I thought this statement summarized it well. So these are young women with active personal and professional lives, and detriment to their quality of life is well hidden between the lines of this clinical trial data. It's important to understand the benefit of these patients, or see the benefit of these drugs to these patients, as well as the toxicity, and I think really more work needs to be done to address the side effects to improve compliance. Typically, we recommend pharmacological ovarian suppression trial prior to surgery to ensure that women do tolerate ovarian suppression before committing them to surgery. So although endocrine therapy may be areas of undertreatment for this patient population, there are two potential areas of overtreatment, which may also lead to disparity. Despite the concerns for undertreatment, there has been a paradoxical increase in aggressive surgery without demonstrated improvement in breast cancer-specific survival. So age is an independent risk factor for local recurrence, but age is not a contraindication to breast-conserving surgery. There is no evidence that mastectomy in this patient population improves outcome outside of established clinical indications. However, there are increasing rates of bilateral mastectomy nationally, even without known hereditary predisposition. This is largely driven based on patient-driven based on survey results. So here's work with a significant number of patients eligible for breast conservation out of the California SEER registry. And you can see here in women less than 40, in 1998, the rate of contralateral prophylactic mastectomy was only around 3%. Then in 2010, that rate was as high as 33%. So there's been a significant rise in contralateral prophylactic mastectomy. Women often cite peace of mind as a reason for contralateral prophylactic mastectomy. However, there is no medical indication for contralateral prophylactic mastectomy, as the rate of relapse in these patients is much higher for systemic recurrence in metastatic disease than it is for contralateral recurrence or a new primary. So this is an opportunity for education also nationally, which is something that our breast surgeons struggle with. A driver of this is also the introduction of immediate reconstruction and improved plastic surgery options, which started around here. So you can see the uptick of surgery really took off with the introduction of this technique. Factors associated with contralateral prophylactic mastectomy included white, non-Hispanic patients, a higher socioeconomic status, an NCI-designated cancer center, and those women less than 50. There are indications in which contralateral prophylactic mastectomy are indicated, and that is high-risk genetic syndromes. So it's a good time to review when women should be tested for hereditary breast or ovarian syndrome. Genetic testing should be offered to any young woman less than the age of 45, regardless of family history, because overall it's a relatively rare event. Results of these tests impact treatment and surveillance recommendation as well as family members, so pre- and post-test counseling is critical for these women to ensure accurate information is delivered. Multi-gene panels typically have a 2 to 3 week turnaround time. We're looking for high penetrance genes such as P53, BRCA1 and 2, and P10. There are also new moderate high-risk penetrance genes listed below here, of which probably 2 is sort of the most common, which work is undergoing to really understand what's the best prophylactic strategy for those women, because the role of prophylactic mastectomy in moderate penetrance genes is not well established. Nccn guidelines for those patients who should be tested for hereditary breast or ovarian syndrome include those patients less than 45 or male, 45 to 50 with limited or unknown family history, a second breast cancer at any age, more than one family member with breast, ovarian, pancreas, or prostate cancer, patients less than 60 with triple-negative breast cancer, and any age with Ashkenazi Jewish inheritance. So prophylactic mastectomy remains the standard of care for prevention in high-risk genetic syndromes. It is the only established modality can actually reduce significantly the risk and almost remove the risk for the development of breast cancer. However, that is not the choice that a lot of women may make. In those cases in which surgery needs to be delayed or is declined, MRI can be added to screening mammogram for surveillance. But it's important that patients understand that this is not a risk reduction, but an attempt to sort of capture the development of breast cancer at an earlier stage. Tamoxifen aromatase inhibitors can also be used for risk reduction, but remain inferior to prophylactic surgery, as they typically reduce the rate in high-risk patients by about 50%, although not well studied in BRCA1 and 2 patient populations. Prophylactic surgery in the moderate penetrance genes is again less well defined. So in patients who choose not to have a mastectomy, body image, actually in patients regardless of whether or not they choose to have mastectomy, body image is a large part of survivorship and distress for young patients. If mastectomy is indicated, reconstructive surgery should be offered to all patients except for those with inflammatory breast cancer. I will mention that this should be true for every patient regardless of age. Even your 82-year-old patient diagnosed should be offered reconstruction if she chooses. But this is a more pronounced need in younger women. Radiation therapy is not a contraindication to reconstruction, but does require multidisciplinary coordination to prevent toxicity and have the best cosmetic outcome. In patients who don't require mastectomy, oncoplastic surgery, skin sparing, and nipple sparing mastectomy can optimize cosmesis and improve body image and lessen distress for these young patients. So I'm very lucky to work with a very strong surgical colleagues who are adept in each of these techniques. Anytime surgery is being considered, neoadjuvant therapy should be considered. So, on your board question, it'll say there's no difference between neoadjuvant and adjuvant outcome for breast cancer treatment, but those trials are based not on modern treatment and in the absence of many targeted treatment and immunotherapy and our current risk-adaptive strategies. Really, the landscape of breast cancer therapy has really radically changed over the last 5 to 10 years, and I would say the majority of patients that I see with stage 2 or stage 3 breast cancer will receive some form of neoadjuvant treatment. Neoadjuvant therapy can improve the rate of breast conservation. It can also downstage the axilla, so there's less surgery required, and provide what's called risk-adapted therapy to decrease the rate of breast cancer relapse. If you increase the rate of breast conservation, you improve body image, which is better for these particular patients. I've included 5 trials here, which I think are important for the landscape of neoadjuvant therapy. And when I talk about risk-adapted therapy, simply we give the patients an established regimen neoadjuvantly and then change their adjuvant recommendation based on whether or not they have a pathologic complete response. This is a validated strategy for both triple-negative breast cancer, for which now immunotherapy is a key part of their neoadjuvant treatment, as well as for HER2 overexpressed breast cancer, for which modification of their HER2-directed therapy is indicated if patients do not obtain a pathologic complete response. Currently, the role of neoadjuvant endocrine therapy is not well established for this age group, but that is a popular trial choice over the next several years, and I do believe we will see an increase in the rate of neoadjuvant endocrine therapy, not just for older women, but now for younger women in this patient population. So a second area, despite the increased role of neoadjuvant chemotherapy, a potential second area of overtreatment is adjuvant chemotherapy. This is specifically for endocrine-positive disease. So age alone is not an indication for chemotherapy, although it's often thought that younger women have more aggressive breast cancer and therefore should receive neoadjuvant chemotherapy. In the age of genomic testing, however, this can be tailored to fit the patient's needs. Chemotherapy choice should be based on biology, stage, and genomics, as well as the patient preference in all age groups. Just as a review, all patients with HER2-positive and or triple-negative disease should be offered chemotherapy in less than 5 millimeters, independent of age. All patients with those subtypes should also be considered for neoadjuvant chemotherapy, independent of age. But the value of chemotherapy in the very young in estrogen-driven breast cancer has been called into question in the age of genomics. We have 2 validated gene expression signatures that we use regularly in the adjuvant treatment decision-making in breast cancer, one called the Oncotype Dx and the second MammaPrint. And these are really designed and studied prospectively in most cases to determine the adjuvant benefit of chemotherapy in women with ER-positive disease. Oncotype Dx is the most well-studied and the one that I will concentrate on today, and is validated in lymph node negative disease and low lymph node positive disease, which is defined as 1 to 3 lymph nodes. Only estrogen-driven disease. These genomic tests are not used in HER2 overexpressed breast cancer or in triple-negative breast cancer. It should be noted, however, that women under the age of 40 are grossly underrepresented in these risk profiles, and so there has been some difficulty in extrapolating the data to this particular subgroup. So initially, this report would appear like this. If patients came into a low-risk group, lowest score, they would not benefit from chemotherapy, and their risk treated with 5 years of tamoxifen alone was very low. If they were in a high-risk category, they would justify the role of chemotherapy with increased benefit here. It was unclear really what to do with intermediate risk. It was sort of treated as a scale, and if you were very close to high risk, you would offer chemotherapy. If you're very low risk, you would discuss endocrine therapy alone. But really understanding the nuance in this intermediate category led to 2 large prospective clinical trials of Oncotype Dx, which is TAILOR-X and Responder. And it was with these 2 trials that really the importance of age and menopausal status became crystal clear in the treatment of women with ER-positive disease. So TAILOR-X is here on the left-hand side of your screen, and was a study really looking at endocrine-positive disease that is lymph node negative. Patients underwent Oncotype Dx testing. If they came back at a low score, defined as less than 11, they received standard of care treatment with hormone therapy alone. Similarly, if they came back greater than 25, already proven scientifically benefit from chemotherapy, they were given chemotherapy plus hormonal therapy. The question really became, again, this intermediate subgroup and what to do with this women. Women were then stratified for tumor size, menopausal status, chemotherapy, and radiation. They were then randomized to hormone therapy alone or chemotherapy plus hormonal therapy. The results of which I'll tell you in a minute here. Responder RX trial was a similar design, but really looking at lymph node positive disease, which was defined as up to 3 lymph nodes positive, and again stratified if patients had a recurrent score of less than 25 to hormone therapy alone or chemotherapy plus hormonal therapy. So TAILOR-X is the first one that we'll report today, and you can see here that there was all of a sudden a very differential benefit based on greater than 50 or less than 50 years old. So TAILOR-X essentially demonstrated that any woman with a recurrent score of 25 or lower who was older the age of 50 had no chemotherapy benefit and could be safely treated with endocrine therapy alone. Chemotherapy was reserved, therefore, for women with a recurrent score of anywhere from 26 to 100, and the chemotherapy benefit was reported as greater than 15%. In patients less than 50 years old, however, that recurrence cutoff for a chemotherapy benefit really came around a recurrence score of 16, with a graduated benefit depending on where you landed on this scale, with your greater than 15% chemotherapy benefit equal to that of a woman older than the age of 50, but then a more modest benefit depending on the recurrence score. So there was a lot of question as to, well, what's the magic between the 50 years old or less than 50 years old. And so they pulled out of this patient population those women in the less than 50 group who were already postmenopausal versus the women who were premenopausal. And they saw that the benefit really had more to do with menopausal status than it did absolute age. So then the question is this benefit that is seen in this young group related to the cytotoxic effect of chemotherapy on microscopic metastatic disease, or is it for the indirect effect of gonadal toxicity causing ovarian suppression? It is unknown, therefore, if we can offer women in this category ovarian suppression and produce the same degree of benefit, but that is something that will be hotly studied in the next few years. Responder had very similar outcome. They then stratified their patients based on postmenopausal and premenopausal rather than the age of 50. And it was shown that postmenopausal women, even up to 3 lymph nodes, had no benefit from adjuvant chemotherapy and could be treated with endocrine therapy alone if they had a favorable recurrent score. But again, there was this differential benefit in the premenopausal age group, suggesting that these women right now still require chemotherapy, but the question remains as to if it is actually the direct effect of chemotherapy or the indirect effect on ovarian suppression in this patient population. So let's shift a little bit to survivorship. 2 aspects of survivorship that I'd like to focus on today are fertility and sexual health. So there's significant late and long-term side effects of breast cancer treatment. As we improve outcome, we really need to pay attention to the long-term effects of these treatments. So we've talked a little bit about body image, specifically in these women, but body image can come under the form of an altered breast anatomy, pain, range of motion, lymphedema. They can have fibrosis of the breast from radiation, pneumonitis. Fatigue is very common in this patient population, is something that we counsel women on in a survivorship clinic. Neuropathy as a long-term side effect from chemotherapy, weight gain based on hormonal dysregulation. Anxiety and depression is reported in up to about 56% of these patients. Most at risk are the very young, prior psychiatric disorders, or lower socioeconomic status. It's important to screen and refer. Most common reasons for depression cited based on survey analysis is fear of recurrence, body image, and relationship and intimacy issues. So to look a little bit at sexual dysfunction, fertility, and premature menopause, because I think those three aspects of survivorship are most pronounced in this age group. So a special consideration for the young survivor is fertility. So up to 50% of young women are concerned about fertility at breast cancer diagnosis. Almost 30% say that fertility has influenced their treatment decisions. This is complicated by a rising trend of delayed childbearing in the U.S. Chemotherapy negatively affects fertility and ovarian reserve. The evolving duration of endocrine therapy is challenging. Up to about 2012, we routinely offered 5 years of endocrine therapy. Now it's more like 10. So depending on when the woman is diagnosed, this duration of therapy is challenging for family planning. Now we add the role of ovarian suppression, which is actually in direct opposition to conceiving. And so there's this tension over wanting what is best for your breast cancer outcome and wanting a family. So I see three main barriers to fertility or having a family after a breast cancer diagnosis. One is this notion of, is pregnancy safe after diagnosis? The second is the role of chemotherapy as well as ovarian function in direct opposition to family planning, and the duration of adjuvant treatment. So women with breast cancer have the lowest chance of any cancer survivor of subsequently becoming pregnant. And so a lot of questions as to why this occurred. And it has a lot to do with our physician perception of whether or not pregnancy is safe. So 40% of women in the survey believe that pregnancy would stimulate a breast cancer recurrence in ER-positive disease and were counseled against becoming pregnant. Additionally, 30% of the women who did become pregnant were advised to have an abortion by their oncologist because of the fear that the estrogen surge with the pregnancy would increase relapse. But this is ultimately proven not to be true. So pregnancy after breast cancer is safe. So you can see here overall survival and disease-free survival 5 years after pregnancy. And there's actually a benefit to becoming pregnant. You see the women, although probably not statistically significant, even with estrogen receptor positive disease, tend to do a little bit better in those who became pregnant. Now, there may be a little bit of healthy mother bias. Women who are healthy enough to get pregnant may be healthy enough to have a better survival. But nonetheless, I think this proves the point that pregnancy itself is not an independent risk factor. And specifically disease-free survival, you see here too, there appears to be no difference between pregnancy and those who do not become pregnant in ER-positive disease, and in all patients, again, a little bit overall survival for those women. 25% of the patients in this study also underwent abortion at the request of their physician, and there was no impact of abortion on disease-free or overall survival. So this refutes the perception that abortion should be used for therapeutic purposes for the breast cancer. All right, so now that we've established that it's safe to get pregnant, how can we help them get pregnant? So there are two treatment-related barriers to fertility for premenopausal women. One is the direct gonadal toxicity of chemotherapy resulting in premature menopause, and the second is the duration of endocrine treatment, which cause delays in conception that allow natural ovarian aging and may be more difficult for women to get pregnant. I do think the latter is more critical than the direct gonadal toxicity. So prior to 2012, we would usually counsel women to try to just wait 5 years for family planning. That seems like an acceptable duration to wait. But now the duration of adjuvant endocrine therapy is 10 years in most cases, and oftentimes in and itself obstructive to family planning. Add the role of ovarian suppression and we don't know whether or not it's safe to interrupt ovarian suppression, as most of the women in those trials received ovarian suppression for 5 years. So essentially we have three main options, none of which are evidence-based. We can initiate tamoxifen, interrupt therapy to attempt pregnancy, and then resume to try to complete the adjuvant endocrine duration. We can complete 5 to 10 years of tamoxifen and then advise the patient to get pregnant, or we could delay therapy to allow them to attempt pregnancy. Pregnancy may be natural or with fertility preservation methods. We don't know yet if it's safe to interrupt endocrine therapy. There is a correlate in low-grade prostate cancer in which endocrine therapy can be interrupted, so it's an interesting concept, and thus is the result of the positive study design, which is currently enrolling. So in this study, we'll take patients with ER-positive disease and allow them to complete about anywhere from 18 to 30 months of endocrine therapy. They are allowed to stop their endocrine therapy, attempt to get pregnant, and then after about a 2-year period, resume endocrine therapy for 5 to 10 years. And then these women will be followed for a total of 10 years to try to understand safety of this strategy. Chemotherapy-induced early referral. This is a very important part of the HERT program. It's early recognition that the sooner you refer to reproductive endocrinologists to look at oocyte preservation or embryo preservation, the better outcome there is. This is Dr. Robert Hunter, who's our community partner at Kentucky Fertility Institute. So the reported rate of permanent chemotherapy-induced amenorrhea is about 15 to 20%, depending on the regimen prescribed. Early referral to a specialist increases the success rate because an induction cycle may take up to 2 to 3 weeks. And so the earlier you recognize that this is important, they can get started the least amount of delay in their treatment. Established techniques include embryo or oocyte cryopreservation. Oocyte cryopreservation has become preferable, largely because it's as successful as embryo cryopreservation. It does not require a partner for embryo production, and it can be done faster. So it has about a 60 to 80% success rate in a less than 35-year-old woman. We also look at the role of GnRH drug concurrent with chemotherapy, which may be protective by stopping ovarian cell cycle. But this is not, again, has only been proven to resume menses and is not a direct measure of fertility. So despite early referral, many patients actually do not use these techniques. They have a lot of doctors and patients have historically had apprehension about safety and techniques. In order to stimulate the ovary, there's a transient elevated estrogen level, and so there was some concern about hormonal manipulation in ER-positive disease. Also, there's a concern that you would have to delay their systemic treatment. If women require chemotherapy, typically you want to start pretty early, as soon as possible, and this can delay therapy in up to 2 to 3 weeks, which for some patients with more aggressive tumor types may not be an acceptable start rate. But the real barrier to utilization of these techniques is financial limitations, as most of these are not covered by insurance, especially in our state. So there are only, I think, 15 or so states that provide fertility insurance coverage. Some of these are regardless of the cause of infertility, coverages applied. Some of these are specific to treatment-related toxicity. But one cycle of an embryo or oocyte cryopreservation can be up to $10,000 or more. These patients are facing high medical bills from chemotherapy, surgery, etc., and simply this is a large barrier to their ability to preserve eggs. Even if the procedure is covered, sometimes the out-of-pocket drug cost is not, and that can also be limiting. There is some philanthropy that is available. Livestrong Foundation has a very generous program to try to help cover the cost of these drugs, but again, sometimes it's not enough. Once these oocytes or embryos are produced, there is a yearly cost of banking the eggs and embryos that also is a barrier. Sexual dysfunction goes hand in hand with fertility, so chemotherapy and endocrine therapy, as we've discussed, can have extensive sexual side effects that impact quality of life during treatment as well as survivorship. So women can have transient or permanent amenorrhea with hot flashes, vaginal dryness, decreased libido, and changes in sexual response. This is, again, true of all women with breast cancer who require these drugs, but remains a significant source of distress for young women. Ovarian suppression, as discussed previously, only makes this more pronounced. So cancer-related sexual problems are not unique to breast cancer, but are quite prevalent in this population. And it's really an interplay between biologic factors that we've talked about, hormone alterations, changes in body image, pain, fatigue, loss of sensation, psychological, which is depression, anxiety, cognitive, body image, negative thinking, religious and cultural beliefs, social norms in terms of what their body might look like or what they're allowed to do to improve their sexual function, interpersonal aspects, which are relationship discord, fear of intimacy, and lack of communication, all relate to sexual health problems. There's a significant impact on quality of life. Overall, the prevalence of some sort of problem in sexual was up to 100% of patients in some studies. You can see significant wide-ranging area of varied sexual dysfunction. So as a result of this, the HER program aligned expertise with our colleagues in gynecologic oncology, as well as this is our social worker, Kim Williams, who we sent for specific sexual health training and counseling to tackle all sorts of sexual health problems. Dr. Sarah Todd and Carolyn Palmer, who's the nurse practitioner that works with Dr. Todd, really help us with the medical aspects of sexual dysfunction in these women. And this is Whitney Pittman, who is a nurse practitioner, works closely with me to really counsel them on the side effects of the drugs and try to mitigate some of these things to get them through their treatment. So this is Jessica. Jessica's a patient of mine who's in the HER program, and this is her son Levi. He was the first baby born of the HER program, so it's something that we're really proud of. Jessica is actually the artist who designed the logo for the HER program, and so she did a piece on her journey, which I'd like to show you now. Just please let me know if you cannot hear the video.
You're never too young to have it, because that's what I was told at the beginning is you're too young. This doesn't happen. This is not something that happens to people your age.
Jessica Randall noticed a painful lump in one of her breasts in September of 2015. The newlywed was 22 years old. Despite her doctors hoping for the best, it was triple positive breast cancer.
Basically, it was a good thing I came in when I did, because it could have gone to my lymph nodes, my bones, everything.
Doctors wanted to be aggressive with her treatment, giving her 24 hours to decide whether or not to harvest her eggs in the event the treatment compromised her ability to have children in the future.
I literally dropped down and prayed and said, hey, I prayed for, guidance on what to do, on where should I go? Should I do this? Should I not do this? And I decided not to.
Randall went through intense treatment, enduring some brutal side effects.
The first round was pretty bad. It ended up on, had 4 of those. It was the bad stuff, hair falling out, very weak, nauseous, couldn't eat.
She ultimately had a double mastectomy, and in fall 2016, she was cancer-free. For the next 10 years, she would have to take an oral chemo medication, and doctors said her chances of getting pregnant on her own were slim.
You're going to probably, we'll go to a fertility place. There's all these steps on if this doesn't work, this is what we can do. And it was literally just the month mark and I was pregnant.
Randall now has a 6-month-old baby boy named Levi. She also works with the HER program at the James Graham Brown Cancer Center, which is for patients 45 and younger who are diagnosed with breast cancer. She hopes her story will empower other young women to follow their instincts and see a doctor if they think something is wrong. Carrie Grace, WLKY News.
So I love Jessica's story because I think that highlights so much of...
Let's go.
Okay, sorry about that. I love Jessica's story because I think it highlights so much of what I've talked about today. She was diagnosed at a very young age. She was 23. She had a HER2 overexpressed breast cancer. She was referred for a fertility specialist but was unable to do it, both based on financial and timeline. She had a lymph node positive HER2 positive disease, so the need to start her therapy was pretty quick. But she was placed on ovarian suppression, and we were able to interrupt her ovarian suppression, stop her tamoxifen, allow her to have Levi, and she has resumed her endocrine therapy and is more than 5 years out, free of disease, which is great for her. And so, that she's Jessica and patients like Jessica is one of the reasons I wanted to start this program, and I'm so proud to work with all these specialists that you see pictured here who really bring a level of expertise to these women that allow them to be treated in a way that optimizes their breast cancer outcome, but also is an important consideration of the side effects and their quality of life. And then we pay very close attention to survivorship issues and overall hope to give these women who are taken at a time in their life when they may be starting a family, starting relationships, starting a career, and really try to let them live a full, successful life independent of their breast cancer diagnosis. So thank you guys very much for allowing me to speak on this today, and I'm happy to take any questions.
Thank you, Dr. Riley. That was outstanding as always. And just want to let everybody know, if you have a question, you can unmute your microphone and ask, or if you would want to type a question in the chat area, I can see that and read that for Dr. Riley.
Hi, Jason, Dr. Riley. This is Satya Krishnasamy from Endocrinology. That was a great review, very informative. Thank you very much. My question was related to the non-fertility aspect of the chemo and therapies for breast cancer. Do see patients with tremendous weight gain, central adiposity, metabolic syndrome, and the aspects of estrogen deficiency, insomnia, hot flashes. So I know the HERD program is wonderful. Is there anything similar to that for those women over 50 also, and also for younger than 50? Is there aspects of looking at pain and those kind of issues?
Yeah, so we, the sexual health team that I put up there was really the genesis of that team was based on the HER program, but that expertise is open to any patient with breast cancer, and it's been extended to bone marrow patients. It's been extended to GYN, so it's really been extended to almost any patient in the cancer center at this point. In terms of the metabolic syndrome, that is another area that's very significant. Weight gain and obesity is directly related to relapse, especially after diagnosis. So we have a team of nutritionists here at the Cancer Center, and we work with healthy lifestyle counseling chronically to try to help these women maintain a healthy weight.
Thank you very much.
Anyone have another question for Dr. Riley here? Again, you go ahead, you can unmute your mic and ask, or if you wanted to type it in the chat area, we can read it for her. We might have. Okay, a question from Dawn Castor over in nephrology. She says, I treat patients with lupus nephritis and cyclophosphamide. You had mentioned charitable foundations that help pay for cryopreservation. Do you know if these resources are specific for cancer patients?
I think the Livestrong is probably specific for cancer patients, but I'm happy to share with you the contact of Dr. Hunter, who's our community partner in reproductive endocrinology, who he's not specific for breast, so I think that might be a good resource for your patients.
Anyone else with a question for Dr. Riley? Might have one more. Oh, that's Dr. Castor saying thank you. Again, just real quick, if you can unmute, if you wanted to unmute your mic and ask something, or again, you can type in the chat area and we can read it for Dr. Riley. Well, Dr. Riley, it looks like you did such a good job explaining it. There's no questions to ask. So I want to thank you again
Thank you guys very much.
Yeah, thank you for an outstanding presentation again, as always, and we really appreciate it. And obviously, as we said, very timely and very pertinent information for everybody. So we really thank you for that this morning. So, and
thank you.
Oh, go ahead. Thanks. And I just want to remind everybody, we will be back here again next week, same time, same channel, 8 a.m. next Thursday. Our guest, it's our annual allergy session, and our guest will be an old friend, Dr. Gerald Lee, who will be speaking about, his title is Recent Advances in Penicillin Allergy Delabeling. A lot of folks here remember Dr. Lee from here at UofL. He's now down at Emory. So again, thank you everybody for joining us, and thank you, Dr. Riley. That was great.